So good evening, everyone present here in this fifth webinar of Maha Smiles, Cleft Care for Every Child. I'm Suchira from Science Integra, and I would like to introduce Dr. Chavi, who is the Program Officer of Smile Train India. Over to you, Dr. Chavi.
Thank you, Suchira. A very warm good evening, everyone. Before we start the session, let me tell you briefly about Smile Train. Smile Train is world's largest cleft-focused NGO, and we support safe and quality cleft care for all the children who are born with this anomaly in India as well as worldwide. In India, we work through a network of partner hospitals, and currently we are working through 125 plus such partner hospitals across the country. In over 2 decades of working in India, till date, we have supported over 7 lakh cleft surgeries. Smile Train has been in collaboration with Fogsy since 2019, and we are extremely grateful for this partnership. Today, I would like to share a new initiative that Smile Train has taken, focused in Maharashtra. We call it Maha Smiles, Cleft Care for Every Child. This is a CSR collaboration between Bajaj Finserv and Smile Train. Can we go to the next slide?
Just a minute, just a minute.
Okay. Yeah. So as I said that we have started a new initiative focused in Maharashtra. We call it Maha Smiles, Cleft Care for Every Child. This is a CSR collaboration between Bajaj Finserv and Smile Train India. And this partnership is to build awareness and support treatment for children with clefts in Maharashtra. We plan to enable 8,000 life-changing surgeries to children in need in Maharashtra in coming 3 years. We also aim to create awareness about importance of timely treatment and timelines of cleft treatment. And this webinar series that we have with AMOGS and Science Integra, we aim to facilitate resources amongst the AMOGS community about diagnosis and timeline. And also we aim to create linkages between the members and Smile Train treatment centers so that children in need as well as the expecting parents both can get prudent and timely help as well as counseling. So in Maharashtra, currently we are supporting 11 treatment centers, which is across 10 cities. And my request to all of you, the audience, is that if you come across such children with cleft, lip or palate, please refer them to the nearest Smile Train center. We also have a toll-free cleft helpline. It is 1-800-103-801. We are also reachable at www.smiletrain.org. So this is all about Smile Train. Today it is my privilege to welcome Dr. Sujit Konkar, who is also the convener for the webinar today. He is the chairperson of Fetal Medicine Committee, AMOGS. Over to you, Dr. Sujit.
Thank you for nice introduction, Charvi. Good evening, respected seniors, friends, and colleagues. We are going to have fifth ECME of cleft lip and cleft palate. This series has been started jointly by AMOGS and Smile Train to spread awareness about cleft lip and cleft palate amongst all of us. We are very much thankful to our president, respected Dr. Rajan Singh Pardesi, Secretary Dr. Sujata Dave ma'am, President-elect Dr. Kiran Kurtukuti sir, and entire AMOGS office bearers for constant support for this activity. I welcome and invite conveners and coordinators today, Dr. Madan Kamble and Dr. Rashmi Kahar. I welcome, I invite our speaker today, Dr. Savitha ma'am, who is going to talk on speech problems in children with cleft lip and cleft palate. Because of some reasons, the another talk is not possible to include in this today's webinar. I would like to welcome our chairperson today, Dr. Seema Tripathi Pandey ma'am, for this webinar. Welcome ma'am for this webinar. We are very much eager to listen to all of you. I would like to introduce Dr. Seema ma'am for the first talk, for the talk of today. That is speech problems in children with cleft lip and cleft palate. CV, please. Dr. Seema Pandey ma'am is president of Azamgarh Obstetric and Gynecological Society. She is National Executive Committee member of ISAR 2018 and 2022 and ISPAT 2021 to 23. She is co-author of A to Z PCOS. Please change the slide. Please change the slide.
Yes, so there's some technical issue. I'll share it again.
Okay. So she is a co-editor of ART and fertility enhancing surgeries, the Synergy, Ovulation Induction Simplified, Foxy Handbook of Drugs in Infertility, and Foxy Focus Preterm Labor. She is reviewer of JOGI, that is Journal of Obstetrics and Gynecology, India. She has been executive board member of Commonwealth Association for Health and Disability. She is having key interest in infertility and reproductive endocrinology, PCOS, adolescents health and early pregnancy failure. And she has been spreading awareness about PCOS and adolescent health amongst rural women and school girls through health checkup camps and talks through NGO Surabhi. Over to you, Seema ma'am, for the next talk.
Thank you, Sujit, for kind introduction, but I don't think I have a talk here.
No, you have to introduce Savitha ma'am.
Yes, so
Yeah,
that's what I was going to say, that I will be introducing one of the great speaker, Dr. V.H. Savitha. Can you
Yes.
just put her slide? Because, yeah, Dr. V.H. Savitha, welcome, ma'am, is a professor and in charge head of the Department of Audiology and Speech Language Pathology at SRM Medical College Hospital and Research Center, Chennai. She's also a consultant cleft specialist speech language pathologist and alumnus of the All India Institute of Speech and Hearing, Mysore. She did her master's in 2013. Ma'am received her PhD from Sri Ramchandra Institute of Higher Education and Research, Chennai, for a research title Early Language Development in Tamil Speaking Children with Cleft Lip and Palate, a longitudinal study. Dr. Savitha's special interests includes training and capacity building for cleft speech services, and one of the master trainers for cleft speech in India, and has been involved in reviewing and expanding speech services across Smile Train centers in India. Dr. Savitha has also designed and executed the Smile Train speech training initiative in Myanmar for the cleft 2017 to 18, and had been the coordinator of the Sri Ramachandra University Smile Train Speech Training Initiative 2008 to 2012. Dr. Savitha has also been conferred this prestigious Breathweight Oration by the Indian Society of Cleft Lip, Palate, and Related Craniofacial Anomalies. Ma'am is a member of the Smile Train India's Medical Advisory Committee and the Smile Train Research and Innovation Advisory Council. I welcome you, ma'am. Over to you.
Thank you. Thank you so much, Dr. Seema, for that wonderful introduction. I'm just going to quickly share my screen. So while I'm sharing, I request all the participants here today to please bear with my voice. It's not definitely in its best form, being a speech pathologist myself. I apologize for that in the first place. I'm just recovering from a viral infection and hence this is, but I will try to do justice through my talk, through the content of my talk. So at the outset, thanks to MOGS for this wonderful initiative of collaborating with Smile Train for spreading the message on cleft lip and palate to all members of the society. And I love the title of the ECME, Maha Smiles, yeah, cleft care for every child. That's a wonderful title, and I think it's more apt in the current scenario. So quickly going on to today's talk, which is on speech problems in children with cleft lip and palate. I'm going to be taking you through a realm of 5 major topics, which I think is important for us to understand, and especially which I would like this particular community of professionals to take forward. So I'm going to quickly take you through a very overall view on how is speech produced, and what happens when there's a cleft lip and palate? What's the impact of cleft lip and palate on this speech production? And even before speech production is a very important aspect that we need to consider, which is development of language as such. So there's a difference when we're talking of speech versus when we're talking of language. So I'll be addressing about that during my talk here. And so that's what will take us to the next topic as to what happens even before speech emerges. And then once speech emerges, what are the cleft speech characteristics? And what are the important points that one needs to counsel parents of children with cleft lip and palate in the early stages, so that some of these speech characteristics can be prevented. That's what I'm going to be taking you all through. If there are any questions, you can feel free to put in the chat box or raise your hands in between the presentation also, if you think, if it may be permitted. We can take it as a general discussion as well. So very quickly taking you all through the process of speech production, there is a lot of interlay between physical factors and learning factors when we're talking of speech production. Speech production basically is a physiological process that involves the respiratory system, the laryngeal system, the articulatory system, the resonatory system, and all of these being controlled by the neurological system. That's what you can see in here, all the systems which are responsible for physiological production of speech. So while the physiological systems are necessary for speech production, one should also keep in mind that producing speech sometimes is also a habit, just like anything else. So the way I speak is a habit that I develop. So I can learn to speak fast. I can learn to slow down my speech. So there's a lot of learning factors that are involved when we're talking of speech production. So both these factors, that is the physical structures involved in speech and the learning factors, both of these play a role when we have to understand the speech production of a particular person. And the same thing applies even for children with cleft lip and palate. Now, in the first place, what happens is right away, the physical structures we know are compromised when we're talking of children with cleft lip and palate. They do not have issues with the respiratory system, which is what I've represented here with the pink shaded labels. They do not have much of an issue with the blue labeled laryngeal system. The moment we come up here, the moment we come to the articulatory system and the resonatory system, which is both indicated in yellow out here, that's where the problem arises for children with cleft lip and palate. They do have compromised structures here because of the presence of the cleft itself. And as a result of which, the physiological system necessary for speech production is compromised in these children. Now, in addition to this, what happens is learning factors come into picture. Now, where does this learning factor come into picture? Children consciously produce speech sounds right from the age of 6 months onwards, wherein we call it a stage of babbling, which is a stage where children are learning to produce speech sounds. The period of babbling between 6 months to 10 months is very, very crucial for all of us as human beings, because this is the stage which is going to lay down the foundation for later speech production in all of us. So as human beings, when babies, I'm sorry, I don't know why my system is. Yeah. So as babies, when children learn to produce speech, what happens is the neuromotor patterns get established during this period between 6 to 10 months. Now, in a child with cleft lip and palate, the 6 to 10 months is a time where the cleft is still present. It is not repaired in the age of 6 to 10 months. So as a result, what happens is the child learns to produce speech in an alternate fashion. Child produces speech with error patterns because the child does not have the needed structures there. And these error patterns sometimes get very strongly established as a neural pattern in the child's system. Therefore, this learned behavior continues to persist even after the palate is repaired, and the child continues to produce some of these error patterns. So that's why I say it's a combination of physical factors or the physical structures and the learning factors which play a role when it comes to the speech production errors in children with cleft lip and palate. So there is abnormal neuromotor pattern because of the errored productions during the period of babbling. There is a physical defect that is present. Now, sometimes there are residual physical defects even after the palate is repaired. The palate generally gets repaired by around 10 months to 1 year of age. Despite the palate being repaired, there could be residual physical defects, like there can be a small alveolar cleft that is still persistent till the age of 7 to 9 years. Or sometimes there are resulting fistula that can occur following a cleft repair. Sometimes there are velopharyngeal dysfunctions. There are other associated conditions that can emerge along with cleft, which contributes to additional physical defects leading to speech production difficulties. And the other factor, which is a major factor that is contributing to the problem, is altered mother-child interaction. Now, we all know that the first year of life plays a very crucial role in the child's development. Now, the first year of life has a lot going for the child, and most oftentimes it is the society, it is the caretaker and the environment around the child who lays the foundation during this first year of time. In this first year of life, it's very important that the mother and child, or the caretaker and the child, bond through the process of social interaction with each other. There's a lot that happens even through the simple process of feeding. Mother maintains eye contact with the child. The mother probably talks to the child. There is an emotional bonding. There is a connect. There's a lot of things that happens during the first year. But when a child is born with a physical defect like cleft lip and palate, this mother-child interaction process gets altered. The focus sometimes gets lost away from the process of interaction and bonding to several other concerns that can arise and emerge out of the physical defect that is present in the child. So because the mother-child interaction gets altered, the communication pattern and the communication development in children sometimes gets affected because of this process. In addition to these conditions, children with cleft lip and palate are also prone to fluctuating hearing loss in their early stages because of their altered eustachian tube functioning. And this function of fluctuating hearing loss can further contribute to the speech problems that we see in children with cleft lip and palate. So because of all of these conditions that can exist in a child with cleft lip and palate, the speech development gets compromised there, or it gets affected in children with cleft lip and palate. So what happens even before speech emerges? For a common layman, or for most people out there, speech is when the child is starting to produce words. But there are a lot of things that happens even before the speech is emerging, which is important for speech production at a later point of time. Like, for instance, the child should first understand the meaning of words. The child should be even producing some word for us to comment about whether the child's speech is all right or not. So there are a lot of things that should happen even before the child is emerging and using words production consistently. So research evidence has now helped us understand what is happening with children with cleft even before speech is emerging. What happens is children with cleft lip and palate are found to have a significant delay in their onset of the first word itself. Most typically developing children develop their first meaningful word or produce their first meaningful word by around the age of 12 months. You can see that with the blue dots that are represented here. But children with cleft lip and palate produce their first words at a much later age with almost a clear 6-month or more delay in the process of first word acquisition. So you can see the red dots here, which shows the age of onset of first word for children with cleft lip and palate. And you can see that there is a delay of at least 6 months between a child who is born typically versus a child born with cleft lip and palate. Now, this delay in language development is sometimes found to even persist till the age of 30 months. So you can see the language age. We measure something called as a language age of children. The receptive language age helps us understand how much they are able to understand. Expressive language age helps us understand how much they are able to speak out or how much they are able to express. You can see a very significant delay in both of these. The expressive language is delayed more compared to the receptive language in children with cleft lip and palate. This is even by the age of 30 months. So if a child has a chronological age of 30 months, we expect them to have an expressive language age of 30 months. You can see a clear delay of 6 to 7 months, even by the age of 2.5 years. So children with cleft demonstrate significant delays in language development, especially on the expressive language domain, and these delays are evident even by the age of 30 months of age. So even before speech is emerging, there is a delay in some aspect that we call as the language development in these children. Now, let's say we are tackling this and children are developing language normally and they're moving on to speech production. They are producing speech in sentences. They are able to converse in sentences. Still, there can be certain characteristics which we call as the cleft speech characteristics that can be evidenced in children with cleft lip and palate. So what are these cleft speech characteristics? And I think this would be what is addressing the direct title of today's talk, that is speech problems in cleft lip and palate. So I was highlighting on the language issues all this while to tell you that there are problems that exist even beyond speech, or even before speech, there can be problems that we notice. But in addition to that, coming to the title, the cleft speech characteristics predominantly revolve around 5 major areas in cleft speech. One is what we call as an atypical consonant production, which is something which most people are able to recognize in children with cleft lip and palate. That is, children with cleft lip and palate are not able to produce speech sounds like how you and I would produce, or how a typically developing person will produce a speech sound. They are not able to produce sounds in that particular manner. So this is what we call as an atypical consonant production. Then we have abnormal nasal resonance. My speech today is a classic example of an abnormal nasal resonance too, but it would be the opposite of what children with cleft lip and palate produce. Children with cleft lip and palate have increased nasal resonance. I probably today have a reduced nasal resonance in my speech. Children with cleft lip and palate also have what we call as an abnormal nasal airflow, which is to do with production of speech sounds. Now, when we produce speech sounds, like P is a sound that we produce with air coming out only through the mouth. But when children with cleft lip and palate produce it, they produce it with sound coming out through the nose. So it sounds as a pa, pa, pa. You can hear the distinct escape of air that comes through the nose when they are not supposed to be letting air out through the nose. Now, there are certain sounds for which we naturally let out air through the nose, like when we produce the M sound or the N sound, the n are all sounds which has air escaping through the nose. But when we are producing the other sounds like the P, B, T, D, T, D, these are sounds for which we do not expect any escape of air through the nose. But when children with cleft lip and palate produce these sounds, so a P would come as ha, a T would come as ha, ha, or a S would come out as sa, sa. It comes out with a very distinct nasal airflow. And when this happens, along with the nasal airflow, they may also have a lot of grimacing around the nasal region in an attempt to control that airflow unconsciously. So there can be a lot of grimacing. And sometimes children with cleft lip and palate can also have altered laryngeal voice quality. That is, their voice can sometimes sound hoarse because of certain mechanisms that I will help you understand in the upcoming slides. Now, we will look into each one of these in depth to understand how the manifestations happen actually in children with cleft lip and palate. Now, to understand the abnormal productions that we see in children with cleft lip and palate, it's important we understand the normal speech production. So looking at articulation, which is nothing but the process of producing speech sounds, one has to remember that we produce speech sounds at different places in the oral cavity and using different manner. When I say manner, it is all the process of airflow modulation. All of speech is airflow modulation. We modulate the speech in a particular manner. Children with cleft lip and palate have certain abnormal ways or have certain different ways of modifying that airflow and therefore produce speech errors there. So let me give you a quick overview of the speech sounds that we normally produce. So what you see here from the top to bottom, that is each row here actually represents the different places in the mouth where we produce a speech sound. So starting right from the lips till the level of the throat, there are different speech sounds that we produce. So that's what we call as a bilabial, that's a p, b sound where the lips are involved. You can have the labiodental, which involves the lips and the teeth, that is a p, v. You can have the alveolar, retroflex, palatal, velar, which are all sounds involving different parts of the tongue against the palate. And then you have the glottal, which is your h sound. So these are all different places in which we produce speech sounds. Now, what you see in each column here are different manners in which we produce sound. That is, each of these sounds are produced by modifying the airflow in a different way. Now, I'll just help you understand two or maybe three major types here. Let's just look at the ones I have indicated here in red, that is the stops and the fricatives. Now, these are sounds which involves the most complex of the airflow modifying mechanism because you need to build up air pressure in order to be able to produce this sound. So a stop is a sound wherein we bring the articulators together, stop the airflow, and release the airflow with a burst. So it is like a dam there. You know, you build a check dam and then suddenly release the dam, releasing the air to bring out the sound. So it is like I bring my lips together and then explode the air out, resulting in it. Those are your stop consonants. So you can understand that there is an enough amount of air pressure buildup that we have to do behind the articulators if we need to produce that sound. On the other hand, we have fricatives where I don't completely close my articulators. I bring my articulators close by, leave a narrow gap and continuously let air come out through that narrow gap. It's like there's a small gap through which air is coming out continuously. Now, both of these requires very complex air pressure modulation, which we all very unconsciously do it. Now, these are sounds which air escapes through the nasal cavity, through the oral cavity. On the other hand, we can have sounds like the nasals, which involves air escaping through the nasal cavity, where you have the all those kind of sounds. That is your, if we look at the Hindi letters, it will be your ma, na, nya, nga. Those are the sounds that come into the category of the nasal sound. Now, why is it important for us to understand this? Children with cleft have difficulty in maintaining this pressure modulation or making these pressure modulations. Children with cleft have difficulty in certain places in the oral cavity. The palate is where the problem is. So the sounds that involve the tongue moving towards the palate is more difficult. So a bilabial sound which just involves the lip could sometimes be more easy for them to produce than the th or a the, which involves the tongue against the palate. So one has to understand the sound physiology or the articulatory physiology to be able to understand what's happening with the children with cleft. So sounds that involves pressure consonant, air pressure modulation, that is your stops and fricatives, that is the sounds like your p, b, th, the, t, d, k, g. These are the sounds which are more difficult for children with cleft lip and palate. On the other hand, a sound like w, y, l, m, n are all going to be sounds which they can produce more easily because they don't require complex manipulation in the oral cavity. So accordingly, we can classify the error patterns of children with cleft lip and palate into 3 types. One is developmental errors, which we all know exist in all children. No child at 1 year is capable of producing all the speech sounds. We know children between 1 to 2 years are still in the process of developing speech and do make certain errors in their speech sounds. Like, for example, if you take the R sound, the R sound is probably not attained by children till the age of 5 years, 4 or 5 years. Sometimes children are producing it early, but for normal acquisition, you will wait till 4 or 5 years. So suppose you have a 2-year-old child who says Raja as Laja or Yaja, it is an acceptable error. So there can be developmental errors that we see in children with cleft lip and palate. So that's not a point of concern at all for us. But the point of concern for us occurs when children with cleft lip and palate show either obligatory errors or compensatory errors. Now, what is an obligatory error? An obligatory error is one which is an error that is occurring mandatorily because of a structural deficit. Now, let's imagine a child who is having a fistula. A fistula means the surgery has been done, the cleft has been repaired, but even after a repair, there is a breakdown and there is a hole that we find in the roof of the mouth. So when a child is having a fistula, with the presence of a fistula, let us say in the palatal region, it is not going to be possible for the child to produce a s sound accurately or produce a th sound accurately because the palate is not there for the child to be able to produce a speech sound. So there is a structural deficit, and the structural deficit is directly contributing to a speech error. Then we call it as an obligatory error. Now, most of the obligatory error will result in alteration in the manner of articulation. So if you look into the previous one, what will happen is there is these errors, that is a stop either gets produced as a nasal sound, or most oftentimes the nasal counterpart is substituted there. So those are some of the obligatory errors that we will see in children with cleft lip and palate. Now, on the other hand, there can be some errors because of persistence of the learnt maladaptive behavior. If you remember, I told you during the babbling stage, because a child has cleft lip and palate, the child learns to produce speech sounds in an altered manner, or a child produces sounds with an error pattern. And those error patterns continue to persist even after the after the surgery is done. Now, what are those kind of errors? Those are errors wherein mostly child makes error in terms of placement. So the child wants to produce a stop consonant at the level of the alveolus. Say the child wants to say the. Child is not able to say the because there is a cleft there. The child moves the tongue backward and probably produces it as a k, or sometimes even backward from the throat as a glottal stop. So the child might produce a sound, a stop consonant produced from the glottis instead. So a word like, let us say, tata can probably sound as which is a sound which is produced by a sudden constriction at the level of the glottis. So these errors, which are placement errors, are generally errors which can be corrected only through speech therapy. Whereas when a child has obligatory errors, we generally do not recommend speech therapy till that structural deficit is corrected. Speech therapy is a treatment that works on the functionality of speech. It does not work on correcting the structures contributing to speech. So obligatory errors, we generally make referrals for further intervention, which could be surgical or prosthetic intervention. But if it is compensatory errors, then those are candidates who are candidates for speech therapy. And children with cleft lip and palate can sometimes produce a combination of these errors. That is, they could be producing a combination of obligatory and compensatory errors. The next error pattern that we commonly notice is nasal air emission, which is, from the name itself, you can understand it is emission of air through the nasal cavity when it is not supposed to. So why does this occur? Nasal air emission can occur in children with cleft lip and palate because of a leak anywhere in the oral cavity. Now, this could be a leak because of a fistula. It could be a leak because of a velopharyngeal dysfunction. I'll talk about velopharyngeal dysfunction while I'm addressing resonance as well. But we need to understand, basically, a nasal air emission can be a phenomenon where there is an escape of air through the nasal cavity when it is not supposed to. So if they have to say, let us say a sentence, for example, like Sita Sat Paise Do, which is a sentence loaded with S sound in it. So the Sita Sat Paise Do can probably sound as I really have to put an effort to bring that nasal air emission now because of my occluded nostrils there. But otherwise, it comes in with a very clear, distinct sound coming through the nasal cavity. Now, to understand resonance, we need to understand the velopharyngeal function. So what can go wrong with the resonance? The resonance is nothing but the quality of speech that each one of us have. We know each person has a distinct voice quality when compared to the other. Now, what determines this is the shape of our oral cavity, the size of our oral cavity. So whenever sound has to pass through a chamber, it has its acoustic properties. It carries some value to it, right? So it is the chamber quality that contributes to the quality of one's voice. Now, what determines this shape and size of the chamber is this structure that is the velopharyngeal port. Now, we all know that when air comes out from the laryngeal system and comes into the articulatory system, it has two passages. It can either come out through the oral cavity or it can also come out through the nasal cavity. Now, what prevents the air from leaking out through the nasal cavity when we speak is because of the functioning of the structure called the velum. Now, what does the velum do? When we speak, the velum goes against the posterior pharyngeal wall and closes the nasal inlet so that air can come out through the oral cavity. Usually, the velopharyngeal port is open. That's why we all are able to breathe through the nose. That's why we are nasal breathers. But when we speak and when we produce oral consonants, this velopharynx or this velum goes and closes against the posterior pharyngeal wall. Now, in children with cleft lip and palate, velopharyngeal dysfunction, that is, difficulty of this velum to go and close against the posterior pharyngeal wall during speech can be noticed as a coexisting condition. Now, when this is noticed as a coexisting condition, what happens is the velopharyngeal port is not going to close, and when the velopharyngeal port does not close, there's automatically an option for the air to leak out through the nasal cavity. So when air leaks out through the nasal cavity, we get what is called as a hypernasal resonance. The quality of the voice itself changes. Now, this is different from nasal air emission. The nasal air emission is a phenomenon that we notice for specific consonants, that is the oral consonants. But in the case of resonance being altered, the entire quality of voice is getting affected. Very typically like what you hear in my voice today. So my velopharyngeal port is, my nasal cavity is running the opposite of what will happen in children with cleft lip and palate currently. Children with cleft lip and palate have excessive engagement of the nasal cavity, and therefore what happens is their voice begins to sound hypernasal. So this is the phenomenon that we see in children with cleft lip and palate. In children with cleft lip and palate, this soft palate remains in this position itself or does not go and close against the posterior pharyngeal wall, as a result of which there is escape of air through the nasal cavity, resulting in what we would call as a hypernasal resonance. So this is inadequate closure. Velopharyngeal dysfunction would be inadequate closure of the velopharynx during speech production. That is what we would call as a velopharyngeal dysfunction. And this condition exists in children with cleft lip and palate. It coexists in children with cleft lip and palate. And identifying this dysfunction and correcting it generally happens as a secondary correction in cleft lip and palate. So we want children to be able to produce. Now, the challenge about velopharyngeal dysfunction is we can assess velopharyngeal dysfunction only if the child is producing a certain quantity of speech. If I do not have a child who is speaking, if I do not have a child who has sufficient language and is not expressing in sentences, I cannot assess for velopharyngeal dysfunction, because the whole mechanism of velopharyngeal functioning involves speech. So therefore, velopharyngeal dysfunction is generally assessed at a later point of life, probably by around 4 to 5 years of age in children with cleft lip and palate, when they are able to produce speech in sentences. We then use a combination of perceptual assessment. We first listen to the child's speech. There are symptoms that we pick up when we pick up hypernasality in the child's speech. Then we do further assessments to confirm the presence of velopharyngeal dysfunction, and then make recommendations for secondary surgical correction of the coexisting velopharyngeal dysfunction. Apart from these, so these are the common resonance disorders that we can see in cleft lip and palate. Hypernasal resonance, which is excessive nasal resonance that we perceive on the oral sounds and vowels. So in this case, the speech is going to sound very nasalized. You hear a nasalized speech there. On the other hand, sometimes children with cleft lip and palate can also have speech like what I am having today. They can have a hyponasal resonance, wherein even my nasal sounds do not have the nasal resonance. And this can happen because of any inflammation in the oropharyngeal cavity. Sometimes it can happen because of hypertrophy of adenoids and tonsils, or any polyps or any conditions which is causing an obstruction in the oronasal pharynx. Children with cleft lip and palate can sometimes also present with mixed resonance, wherein there can be a combination of both of these factors. But on the whole, the quality of voice, the quality of speech output is compromised because of the presence of resonance issues in children with cleft lip and palate. The next condition that we will see in children with cleft lip and palate can be dysphonia. This is not something that we notice in all children with cleft lip and palate, but we can see almost in 30 to 40% of children with cleft lip and palate, wherein they are characterized, their voice is characterized with breathiness, hoarseness, or sometimes have a very low intensity, or sometimes even sound as a very glottal fry during their production. Now, why do we see this function in the laryngeal system? The laryngeal system basically is not compromised in children with cleft lip and palate, but some of the productions that they can engage in, like I told you, for example, a glottal stop. Now, children with cleft lip and palate exhibit productions of glottal stop because they want to prevent the losing of air at the level of velopharynx. So they want to produce a sound before they lose the air pressure at the velopharynx. So they constrict the air at the level of the glottis. So when they are doing, or when they are engaging in excessive glottal productions, there is an overuse of the laryngeal system than what it is meant to be used for. So when there is an overuse of the laryngeal system, this hyperfunction of the laryngeal system can result in certain voice disorders, which manifests as dysphonia in children with cleft lip and palate. That's why we do not see this commonly in all children with cleft lip and palate, but we can appreciate it in almost 30 to 40% of children with cleft lip and palate. So those are the range of symptoms that we can see. Just to quickly sum up on what is it that we see there. So we can see atypical consonant production, that is abnormalities in speech sound production. Most commonly what we notice is they produce the sounds back in the oral cavity rather than producing it in the right place. And they produce the sound with a nasal air escape, which can result in abnormal nasal airflow. They can have nasal resonance issues. They can have grimacing around the nasal cavity. They can have altered laryngeal voice quality. These are some of the abnormal speech characteristics or the speech problems that we will notice in children with cleft lip and palate. Now coming to the most important part, or the most relevant part for each one of us, what needs to be done? What do we do about this? Or is there something that can be expected to be done by each one of us to what is our role in helping prevent this problem? First and foremost, one has to provide support and information regarding communication development to parents. Now, that's very important that parents understand about communication development. Parents have a sense of or have a basic idea about the development of communication so that they know what is it that they need to watch out for so that they can identify the red flags. It's important to emphasize on normal parent-child interaction. And this is very, very important, especially in instances when we have children born with congenital anomalies. Because what happens is when there is an anomaly, when there is an abnormality that happens at birth, this interaction should actually be on the higher side. But what we notice is this interaction goes on to the lower side. I've had parents who sometimes when they come to me at 1 year, and as part of the assessment, one very important thing that I generally look into is how is a parent-child interaction? And when I just leave the parent and child in a room with toys and tell them, play with your child and interact with your child as you would do normally, there are parents who sometimes say, my child just plays on his or her own. I really don't have much interaction that goes on between me and my child when my child is playing. So sometimes the situation is that bad. So it's very important that we emphasize on normal parent-child interaction. Facilitate sound production and vocabulary development. Sound production can actually be facilitated through a lot of playway manners. Especially in our Indian cultural scenario, there's a lot of games that we engage with young children through which speech sounds can be developed. I'm sure if all of you think back and recall your childhood days, there'll definitely be some or the other sound games that you would have engaged with your parents or your cousins or others in the family. So parents have to be encouraged to engage with their child in normal interaction. Use a lot of environmental sound imitation. Just by environmental sound imitation, a wide range of sounds can be taught to children. Like for instance, bow bow can be used for teaching, that is a dog bark can be used for teaching ba sound. You can use a hiss of a snake, goes a snake to teach the s sound. Tuck, 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 a door knock can be used to teach the t sound. The bird song, kaka, kiki, cuckoo can be used to teach them the k, g sounds. So there are many sounds that can be encouraged through playway manner by environmental sound imitation. And from there, you can facilitate vocabulary development as well. Children learn the vocabulary in the early days based on the sounds they're able to produce the most. So what happens in children with cleft lip and palate is because they are able to produce only limited set of sounds, their vocabulary also tends to become limited. So once we facilitate speech sound production, once parents are taught how to engage in interaction with their children to facilitate sound production, then their vocabulary development can also be facilitated. Parents also need to be taught about preventing development of error patterns. Suppose you have a child who is engaging in excessive glottal production. Parents need to be taught to identify those glottal productions and ignore some of those and not reinforce some of the glottal productions. So when parents identify children to produce glottal production, and if the parents substitute those glottal productions with correct productions, appropriate modeling takes place for children to start learning to produce the right sounds. That's the first step towards right sound production. So we need to look at preventing development of error patterns. We don't have so much studies in the Indian scenario, but there are a lot of studies in the Western scenario where preventive intervention methods have been adopted, where parents in the young stages itself have been trained to identify some of these error patterns and facilitate interactive patterns so that some of these errors can be avoided. The other thing is provide early intervention for identified problems. That is also our role. I still come across many parents who come to us at the age of 5 years or 6 years for the first time. Why are they coming to us only at the age of 5 or 6 years? Somebody somewhere has told them, you wait till your child starts speaking, then you can go to the speech therapist. Sometimes it's too late to correct some of those patterns at that stage. Ideally, as soon as the palate is repaired, we would love to see children with cleft lip and palate so that we can start working with the parents. We can do a lot of parent empowerment towards preventing some of these error patterns. So as My request to all of you professionals out there would be to emphasize on this message that early intervention is very, very essential, and parents need not wait till speech problems emerge to come and meet a speech therapist. And yes, of course, another important role is we need to motivate the team for early referrals, and which is one reason why Smile Train engages with such programs as well, because it's important to communicate the message across that intervention can really start early. So if we keep all of this in mind, I think we definitely can go a long way in bringing in a smile in every child's face and at the appropriate time and age. So quickly, to sum up, children with cleft show delay in the development of language, especially with the development of early words, articulation and resonance errors, that is in terms of not being able to produce certain speech sounds, in terms of abnormal quality of speech, can be noticed very commonly in individuals with cleft lip and palate. And this problem becomes worse if the patient is operated late or inexpertly. Early intervention should include parental empowerment, especially focusing on language development. Correction of the structures is an important prerequisite for correction of the speech deficits. Early the structural intervention, better is the prognosis. Continuous monitoring of speech development is essential through the developmental period. With that, I will stop my talk and I can take any questions if there are. Thank you.
Thank you so much, Dr. Savita, for such a wonderful presentation that you have made on this very, very burning issue. In fact, though we are clinicians and gynecologists, and we do find that when a patient comes with a second pregnancy and she still has a child, with a cleft palate, and that is the right time when we can counsel her to actually get this treatment done. And I too acknowledge the presence of the Fetal Medicine Committee of AMOG's chairperson, Dr. Sujit Konkar. Nice to see you, Sujit. And we are. It's a very good talk, which I feel is very much essential for gynecologists as well, within the clinical practice, to know these things, because unless we are aware of counseling the patients earlier, they will lead to a child which will later on will not be able to really correct itself. It is if the children, they are not operated earlier during the course of their growth. So I thank you, Dr. Savita, for a wonderful presentation. We all know that Dr. Savita is a professor and in charge head of the Department of Audiology and Speech Language Pathology at the SRM Medical College Hospital and Research Center. And it was a wonderful talk that we had on speech problems in children with cleft lip and palate. So if there are any more questions from the audience, we would invite them, and we would like to share the other avenues on this therapy as well, if there are any.
There's this one question that's come in the chat box. Can these babies have perfectly normal voices after surgery? The answer to that is yes, but there are a lot of factors that contribute towards this. There have been children with cleft, repaired clefts whom I have listened to and wondered if this child ever had a cleft of the lip and palate. I've had many children like that who has made me wonder also that, did this child really have a cleft of the lip and palate? They've had such beautiful developments there, but there are many factors that contribute to it. If everything goes in the right direction, if everything goes, yes, it is definitely possible to have perfectly normal voices.
Thank you, Savita ma'am, for your wonderful presentation. Thank you.
Nice to see
you. Dr. Nimish sir, very good evening, and thank you for joining.
Good evening. So nice to see you all. Yeah.
Thank you for your kind inputs and sharing the session. Thank you, sir.
It's very important. This topic itself is important. See, we have to correct ourselves. We have to fill the lacunae of our knowledge. We all have a lot of knowledge, but then in this area, we sometimes we do not counsel our patients enough. So that's what we feel when we listen to this talk. And there are many things on this which are an eye-opener. The way by each muscle that can work in the laryngeal area, which is a defective, and what is the reason why a particular resonance takes place when the child tries to speak, is so nicely elaborated by Professor Savita. It was really a very enlightening talk that I listened to, and I thank her and all of you for remaining present for this great meeting of EMOGs, all of us. Seema is here, Dr. Seema Pandey. Seema, welcome to the EMOGs meet.
Good
Dr.
evening,
Seema,
sir. Good
good
evening.
evening.
Thank
Seema
you.
is the president of the Azamgarh Obstetrics and Gynecological Society of Uttar Pradesh. And we also have Dr. Rashmi Kahar, a very old
Hi,
friend of
Rashmi.
ours. Rashmi, nice to see you.
Thank
And
you,
each
sir.
one
Thank
of
you
you,
very much, and
it's a
welcome to
great
the
pleasure.
EMOGs platform.
Charvi, you are also a part of the technical team, and you are with us, and very nice to see all of you. I wanted to ask Sujit, because he's on the fetal medicine committee. Sujit, the fetal medicine is such an area that is it possible to detect these cleft palate issues much earlier when we do the fetal ultrasound? And if it is so, is there any option of fetal surgery? Because I think it appears to be too high-handed at this stage, but in future it could be possible. So I would like to know from you, being a fetal medicine expert.
Yeah. With the with the advent of new machines with great resolution, you can diagnose cleft lip at the gestation age of 12 to 13 weeks also. But diagnosis of isolated cleft palate is very difficult. It needs special maneuvers. The baby should be in specific position with hyperextended neck and so on. But routinely, what we advocate now in your routine scan to see the equal to sign of uvula for low risk patients. If it is seen, it rules out isolated cleft palate. Cleft lip diagnosis is very easy on ultrasonography. But what problem lies is the diagnosis of isolated cleft palate. So it can be diagnosed at around 12 to 13 weeks. And now regarding the intrauterine surgery about spina bifida is now published cases in some countries. But intrauterine surgery for cleft lip and cleft palate is not documented yet in any literature. But in near future, you may expect some good things from other countries also with some good institutions for this. Because it comes up with a very low, almost nil scarring on the parts.
So, if this is missed out on ultrasound, Rashmi, can you do you have any patients whom you must have seen and had a problem later when the baby was born? There was a cleftlet that was missed any time during your
Yes, sir.
For yourself or for a colleague. Yes, it happened anytime.
So when I used to work in government sector, we have seen the patients which were undiagnosed antenatally.
Yes,
so it's a very psychological shock or trauma to the patient and the relatives especially. Why? Because as we agree, this is an aesthetic problem also. And so when we already or antenatally diagnose a congenital anomaly, we inform the parents and relatives, and we make their minds prepare for accepting the anomaly, and we think about the treatment. If this goes undiagnosed and with a fetus or child born with a cleft lip or palate, when we hand over the baby to the parents or the relatives, and then you also will agree that there are so many social taboos in our society about the cleft lip and palate, especially in the rural area. So it's a sort of a shock to the patients and families and relatives. And not only that, when we have started doing these webinars all over, sir, all over the districts, we have actually come to terms with how in-depth the problem is. Not only the psychosocial factors, but also the economical factors associated with the treatment, the surgical problems, and then the time taken for the corrections, and then rehabilitation. And we have come to know that it's not only the patient or the relative or the obstetrician or the sonologist, but also the peer group who would support the parents and the family, and also the psychiatric or psychiatrists who are going to counsel the families. And I must say, sir, that Smile Train is really doing a wonderful job in this regard.
My real compliments to you about the Smile Train, the entire team, which is working on this, and it's such a great organization to help this kind of problem, which is which is like a volcano. You don't realize it, but once the baby is born and when it starts to grow, the entire misfortune on the family and the baby's speech and all comes into the forefront, and then everybody gets worried. So it's a very, very important issue which has to be addressed as early as possible. Madan, you have any case where you had like what I asked Rashmi, the same question, that you had done an ultrasound or your colleague had done an ultrasound and there was no abnormality, and later on the baby was born with a cleft lip or hair lip or a cleft palate, and then something had to be done. I mean,
Actually, recently I didn't get any case, but a few years back this happened. Actually, I'm not doing the anomaly scan.
yes.
My radiologist is doing.
Yeah.
But recently I didn't get any case.
Right.
But previously I had
But sir,
encountered with.
occasionally it can happen. I mean to say it's very difficult to diagnose solitary cleft palate. So
Yes.
in clinical situations,
Yeah.
sometimes it can happen, sir, that a case may go undiagnosed. It
Yeah,
can
what ISO guidelines say that it is just you have to see lips. Palate is not mentioned in the guidelines. So even if you miss out isolated cleft palate, it's not a big issue. But you have to be perfect in your imaging. You have to look for all those things which are not advised or which are not mentioned in the guidelines. So that is how you
Exactly.
become
See,
perfect.
why I'm discussing this again and again is for medical legal reasons. You see, we all work with a very positive approach. We don't want any problem for the patient. Never will a doctor or a gynecologist will ever have that in mind that something goes wrong. It's the only thing is that you see once when the baby is born, there is very difficult to make other people's mouth shut. They want to criticize, and these issues are faced by many clinicians. So we have to be very careful in handling this situation. So Savita, can you tell me, Dr. Savita, what is the incidence that you find of overall cleft lip and hair palate, this type of babies in the population that you are seeing? Does it vary from population to population? Is there a genetic variance? Is there an ethnic variance in this issue?
On an average, we see around 1 in 700 live births is the incidence that's reported, and the incidence in India is also roughly around the same. It's not drastically different.
Yeah.
But I would just wanted to add my one comment of mine. Of course, it's purely anecdotal what I'm going to be talking about, but with regards to the antenatal, identification of the cleft in antenatal, I've had quite a bit of my patients where the second child has had an issue with cleft lip and palate. Most often times they have been very careful during the antenatal diagnosis, and they have looked specifically in that angle, and there have been instances where they were able to identify that the second child will also be having issues with cleft. There have been a couple of instances where we've had patients who came and talked to us about it, but of course mine is purely anecdotal. But first child with cleft lip and palate, antenatal diagnosis, I haven't had many parents come and tell us that it was identified in that stage itself. Most often times it has been missed. Though, of course, the professionals here will be better people to comment on the technical aspects of those, but my pure anecdotal experience or observations on this.
Yeah. Thank you so much. In fact, I really wish we had a pediatric surgeon also on this very knowledgeable panel of various experts. He or she could have told us what is the best time to operate on these patients. But if you can tell us, when would they indicate what's the best time for surgery?
Sir,
it's post after birth, naturally. It has to be after birth. Yeah.
So cleft lip is generally operated at around 6 months of age.
Yes.
And the palate is operated anywhere between 10 months to a year. A lot of factors like the growth and development of the child, the hemoglobin levels of the child are all determining factors which say whether a child can be taken up for surgery or not. But generally, this is the age at which the repair takes place. There are, of course, variations in the timeline depending upon what is the type of surgery somebody wishes to adopt. There are surgeons who prefer adopting whole in one, that is, they operate the lip and the palate together in the same surgery. In such instances, the surgery happens slightly later, close to around a year is when the first surgery takes place, but otherwise in 2-stage, the first surgery happens at around 6 months of age. That is the thing. There are specific guidelines available for this, sir. And in fact, the Smile Train website has all of these guidelines very beautifully laid down in terms of what is the specification for each of these parameters as well. So looking at the growth and development of the child, hemoglobin factors are all predetermining factors that determine, but otherwise lip repair around 6 months and palate repair around 10 months will be the yardstick, sir.
Thank you. Thank you so much for giving us a very accurate timeline, which I think we should all implement in our clinical practice, because we are all clinical gynecologists, of course, first, and then we are specialists or fertility experts or whatever we are in the fields of fetal medicine or ultrasound or say urogynecology or whatever. So various areas which we have touched. In fact, I would like to know from you also, is there a predisposition to a particular genetic sex? Is this more common in males or in female babies?
Yes, sir. It is found to be more common among the males than in the females, as with most of the developmental conditions, sir.
Seema, you have any idea about this type of patients in your practice who have delivered such babies?
Pardon, sir?
Any idea about cleft lip and hair palate babies born to patients whom you have treated or your colleagues have treated?
Yes, one thing I've been noticing in change in last 20 years during my practice, sir, that cleft lip and cleft palate is not as common as when I was student and I used to see in this area where particularly where I am practicing. So yeah, and this Smile Foundation kind of runs in UP too, and like there are people, there are hospitals they have been doing. I had 2 or 3 patients. I sent them to that Heritage Hospital in Varanasi is one place where the Smile Foundation is working. So they have been treated like. I'll just take a call, sir. Thank you.
Yeah, thank you. So any more inputs? Madan, what you have anything else you would like to contribute on this topic?
No, sir.
Right.
So there's only one thing I would like to say, sir, that if it's been diagnosed antenatally, the condition, and if you are able to very well consult the patient and the relatives about it, and if we are able to give them an assurance that this is a correctable condition and the child will have a normal or near normal life afterwards, the correction. So the chances of continuation of pregnancies with this diagnosis are very high.
Of course, this is not an indication of termination of pregnancy.
These pregnancies normally continue to term. They don't have issues like the other type of anomalies where there is a risk of prematurity and or IUGR. They do progress quite normally.
It should not be syndromic. Isolated things are having a very good prognosis.
Yeah.
At least they're well prepared to accept the child, sir. The denial phase is bypassed if we are able to identify them and have them mentally prepared for that process. And that goes a long way in compliance in intervention also. Once they're mentally prepared, their compliance for intervention is much better.
Professor Savita, could you tell us something which you have published on this in this field on this issue about cleft palate, hair lip and cleft palate? Are there any publications you have or any research which you have presented which is worth knowing? I mean, you have drawn a lot of conclusions which are very, very important for us and for every medical person, to know. But anything interesting in research that you have noticed recently about any recent advance that you have noticed from yourself, from you have heard from other scientists?
So I'm basically a speech language pathologist. So my core research in this area has been on the early language development, which is based out of my thesis actually. So that is one where we looked at studying the speech sound development. It was a longitudinal study trying to see how speech sound development happens in children with cleft lip and palate. So that's where we found, of course, there's a lot of literature in the Western world, but the patterns of language development differs across cultures as well. So if we look into the speech sound development patterns in our languages, what we noticed was during the stage between 6 to 10 months itself, that is what we call the babbling period, children with cleft lip and palate have reduced variety of speech sounds that they are producing in the babbling. And what happens is, because the variety of speech sounds that they produce there has reduced, their vocabulary is also kind of getting constricted because of that. To some extent, they are able to compensate with the vocabulary development, because what happens is they produce the word, but they produce a word with the error pattern in it. And because our families are more accommodative, we kind of interpret for the child. So the child continues using a vocabulary, but with the error pattern. Like, for example, if they have to say a word like, let's say, tanni, instead of saying tanni, they might say it as nanni, because na is easy for them to produce. Or they may produce tanni with a glottal production. It goes as anni, right? But our families interpret the anni for the child, and the child starts learning anni for water at every point of time. Right. So there is an interpretation that is taking place because of that, and that dynamics has an impact on how language development takes place in children with cleft. Some of these works have been I have published this in this journal called The Language in India. That is one in which there are a couple of articles pertaining to the language development in children with cleft lip and palate, which is more coming up these days. So as a result of that, we are now moving to see and develop early intervention modules for children with cleft lip and palate, because in the past, speech therapists would not see children with cleft lip and palate till they are maybe 3 or 4 years of age. That was how it was.
Yeah, it was very late, almost very late to do anything later on.
Yeah, even referrals would come to us. The average age of referral to a speech pathologist in the past used to be only at around that time. But now we are changing that trend, and we're saying we want to see them. So now in most of our cleft clinics, most of the smile train centers, the speech pathologist sees the parent and the child at the time of palate repair. And that's brought about a remarkable change in how some of these children are developing speech and language. So that is one thing, sir. Another one, which is a summary of the speech problems that we see in cleft lip and palate, has been published in the Indian Journal of Plastic Surgery. You can find some references and articles to read in that as well. So that's another one where there's articles pertaining to cleft that has been published.
Thank you very much.
But I think that was a very important point brought about by Nimisha, that there should be some research articles published in this regard from our side also. And sir, one more thing is that we should start doing we have had a talk with the smile train people, that we should start with having a registry of these patients actually. And that will give us a clean and clear-cut idea about the prevalence and the incidence. And I think then we can move further forward about it.
Right. Is Dr. Ashwini Kale with us? Because she's a Young Talent Promotion Committee of chairperson of AMOGS, and we wanted her to participate as well. But I think when we started the program, she wasn't there. But is she coming? I would like to know from the technical support team if she's going to join us.
No. Actually, she couldn't join today because of some medical emergency. She couldn't join.
No problem. Of course, you all know Madan. Madan Kamble is the chairperson of the AMOG's Aesthetic and Sexual Medicine Committee, and he's a consultant gynecologist, being a aesthetic gynecologist and sex counselor. And in fact, your committee, your Sexual Medicine Committee, is one of the very high-ranking committees in Foxy. Recently, I have come to know, and I congratulate you to be a part of that committee. So,
thank you, sir.
Very happy to know that we have a member from that committee today with us. And,
yeah, thank you, sir.
Yeah. Any inputs from Dr. Seema? Would you like to give any inputs on this particular subject? from your side, because since you are from the north in Uttar Pradesh and you are from Azamgarh, which is not a very big city also, but it's a hardcore, Uttar Pradesh, North Indian, area where these abnormalities could be existing, and from our side, from our part of the country, we have lesser idea about what is the incidence there. So anything else
sir.
that you would like to add from your side?
Sir, that's what I was telling since I started practicing in this area. In fact, I practice in a village. This is not even district headquarters, this not even taluka, market, village, not even market, outside of the village. And as I was mentioning earlier, when I came to this area for the first time, incidences of cleft lip and cleft palate seem to be very high as compared to what I'm looking at right now. And there are different groups who are working towards this. And this is, let me tell, that this is a very good initiative by Smile Foundation, and this Maha Smile Maharashtra chapter accolades and applaud around of guys for taking it further. I don't know whether these people, Bharat Serum and Science Integra and Smile Foundation, they are doing it in UP as well. I don't think with gynecologists. So I would love if they come to this area of the country as well, and that will really be beneficial for the patients of this particular part of the India, which is really, really very poor.
Nice. And Professor Savita, I had one important question to you. Those patients which you have seen or in your clinic and probably have treated at the same time, giving them guidance, was there any history of any toxins or any abnormal teratogenic drug that the mother could have taken during pregnancy that led to this anomaly?
I'm sorry, sir. I don't think I have enough information to substantiate that.
Sujit, this is one question which is of your territory, fetal medicine. Any drug, any pesticide, any agent, any external, some passive, inhalation, or because nowadays we live in an environment which is not very healthy. There are too many dust particles around wherever we go. And what do you think? Is there any link?
Yeah. Their role has been documented in the literature, sir. Even some anticonvulsants has been mentioned in the literature, but details yet to be put on the board, sir.
Right.
There is a role of these external drugs, yeah. Definitely there is a role of these external factors. There is the role of teratogens also.
Yeah.
But we have to dig out the detailed information.
So I think we have discussed this topic threadbare, I would say, all along, and I think we come to the end of the session. If everybody is happy with what we have discussed, and if there is anything more, I leave this open. If you have any other questions to ask, please feel free. Otherwise, we can conclude this session.
So from the MOXPAC platform, we wish you and Seema Madam all the best in your future endeavors.
Thank you. You know that.
Thank you, Rashmi. That matters a lot, and please support me and sir.
Yes, support. We all support you as Seema as well, and of course, when I am also contesting, I will also need the support and votes from all of you, and we all have to work together. I feel it's an important thing to be all together in united fashion that we work.
True.
And in fact, and after a certain stage of life, let us look at it this way: very without any ego, that we all learn from each other ultimately, because we share our experiences.
Very true,
When we share them, we become more stronger. Our convictions become strong. Our scientific applications become stronger. And that is how you see all these type of webinars as well as conferences make us more and more sound in our knowledge. And that is what really enriches us. So I'm so happy to have you all on this platform. Being president of ISAR Gujarat chapter, I've been the past president of SOGOG also, All Gujarat OBGYN Societies, and also the vice president of FOXY. I am one of the founders of ISAR. 32 years ago, we founded it with Dr. Mahendra Parikh. And I have been told by so many friends and seniors to contest this time that I couldn't refuse them, and I cannot fail them also. So I'm also working hard on these elections because you cannot take any elections for granted. So please support us, please vote for us, and tell all your friends to do it. 11th January, the links are opening on isar.evote.co.in, and to be open till 20th of January. So thank you all very much.
Sure, sir. Sure, sir. I want to mention one thing, sir. Me and Rashmi also contesting for Foxy elections in August, next August.
Yes, yes, yes.
All the
And
best.
I know.
Thank you so much.
Rashmi's flyer I saw in one of the posts in one of the WhatsApp groups, and I'm happy to know that you are also joining, and we are there with you. I can get the entire Gujarat joining.
thank you, thank you, sir. Thank you, sir.
All the best, Rashmi and Dr. Sujit. And please
Yes,
request
ma'am, definitely.
whosoever is a Sarian, please ask your friends, Savita ma'am, too. Please ask them to support us.
Sure, ma'am. I will
For
spread the message
librarian
around.
Isar.
Sure. From my end, thank you, folks in the
Your talk
Amongst group.
was really excellent. It has covered everything, so many things we didn't know even about. It was really fascinating.
Thank you so much. Sir, for the benefit of those who would be interested, I've just shared the link to the comprehensive cleft care timeline guidelines that has been published by Smile Train on their website. I've just posted the link in the chat for those who are
Yes,
interested.
I did open.
Yeah. So thank you so much for this wonderful opportunity.
One important announcement I wanted to make: those who are contesting Foxy elections, I would tell them to come to Foxy conference we are holding in Surat, which will be on 6th and 7th of July. It's a Foxy conference for 2 days. It will be organized by Surat Obstetrics and Gynecological Society, and both of you are welcome as faculties. So keep in touch with us.
Sure,
and
sir.
we can have you there. And I also thank the backbone behind this entire podium and the platform, and that is Suchira as well as Charvi. Both of them are have been working very incessantly to bring us together and share all this knowledge. So thank you again, Suchira and Charvi, both of you. Suchira has been behind me for last 10 days, and we have been communicating to get this this entire program ongoing. And it's my great pleasure to be in AMOGS. Because I was once upon a time I was a member of also Mumbai Obstetrics and Gynec Society as a Wadia resident at Bombay. So it's like my homecoming, and being with you all. So nice of all of you to be here with us. Thank you very much. So can we conclude now? If everybody
Over to Dr. Madan for concluding remarks.
Yeah.
Yes.
Vote of thanks you can.
It's time to mention vote of thanks.
Yeah.
On behalf of AMOGS, I would like to mention my wholehearted thanks to office bearers, President AMOGS, Dr. Rajan Singh Pardeshi sir, President-elect Dr. Kiran Kurkodi sir, and Secretary Madam Sujata Dalvi ma'am, and my co-conveners Dr. Sujit sir and Rashmi ma'am. I mention my thanks to the esteemed chairpersons, Dr. Seema Pandey madam and Dr. Nimish Shalat sir, for joining and giving valuable inputs to the today's webinar.
Thank you.
I also mention my thanks to speaker Dr. Savita ma'am for a wonderful talk and wonderful discussion regarding this cleft lip and cleft palate. It was really a wonderful session. And Dr. Ashwini Kale ma'am couldn't join due to some medical emergency. I also mention my thanks to the Smile Train, the entire team of Smile Train for arranging this series of webinar.
One query: Smile Foundation and a Smile Train, are they
Thank you
two different
once
platforms?
again.
Yes.
Yes.
They are different.
Sorry.
Thank you all.
And special thanks to Dr. Madan Kamble for taking his time from his busy schedule and joining us as convener today. Thank you, Dr. Madan.
Thank you. I wish you all the
Thank you
best,
all of
all
you
the
again.
contestants going for Foxy.
Thank you all. Wish you all a very happy new year in advance.
Yes,
Thank
ma'am.
you.
Same
Same
to
to
you.
you, all of you.
Thank you.
And
Thank you.
thank you, Dr. Madan, for this opportunity, and Science Integra. Bye-bye.
Yeah. Thank you.
Thank you, everyone, for
Yeah,
joining.
bye.
Yeah.
Bye.